screening and detections. And this is a platform where implementing partner can learn from each other. So we very much encourage people, please participate by asking questions during the presentation and in the chat groups, or ask the question live after the presentation is over. And for the webinar, we will be recording them and we'll be posting them on the SOPTV's website. All of you who attend this meeting, we will share the link to access the recording and presentation materials, like the PowerPoint slides, after a couple days after the webinar is over. So just stay tuned. And then finally, at the end of each webinar, we usually ask participants to give us a feedback through a short survey to help us understand what are the topics you would like to hear from future webinar. So without further ado, today we have a full program. First of all, I think I want to welcome the NTP manager of Uganda, Dr. Stavia, who kindly agreed to give us a keynote speech to welcome us to open the session. And Dr. Stavia is someone who doesn't need any introduction. She had been working in public health over the past 15 years and had extensive experience in both clinical care and the programming of infectious diseases. So in her position, she oversees the provision of care and treatment services for DS and DRTB, TB preventative therapies, and the leprosy. And she has been very active in facilitating the rollout of digital X-ray and CAD technology to improve case detection in Uganda and internationally. So without further ado, Dr. Stavia, the floor is yours.
Thank you. Just briefly, for those who don't know how Dr. Stavia looks like, you're all most welcome to this webinar. I'm happy to be speaking to you, and thanks for the opportunity, STOP-TB. Uganda is, as we know, one of the highly burdened TB and TB-HIV countries. And we are looking at every opportunity that presents to see how we can get out of this situation. Our annual TB incidence is of about 90,000 new people falling ill with TB disease. And our efforts to find them still continue to fall short of identifying all of them. So the use of artificial intelligence and digital X-ray equipment is a key addition in improving our quest for identifying missing people with TB across the country. We are happy that we have received support from the STOP-TB partnership to expand this effort, both at implementation research level, but also programming level. We appreciate this addition, and we observe improvement in the yield, at least in the reach for people who do not access quality screening for tuberculosis, being reached with the mobile digital X-ray equipment. Today, we'll be learning from one of our partners that we have worked with, IDI, in the Prime TB project, to try to customize the screening for TB using X-ray. When we started, we've been using 50% as cutoff based on what we found in the guidelines and from the manufacturer's recommendations, to see those above as those that are likely to have TB, but we continue to learn a lot. So this Prime activity is one of the research projects that we have undertaken with our partners to try to see whether that is actually working at the facility or not. there are more of these that we'll be doing to see whether what we see at the facility applies at community level, so that we can be able to further make use of these approaches to improve and reduce our missing people with TB. So I want to say thank you to the Stop TB Partnership again. Thank you to everyone who has logged on to this webinar. There is a lot to learn from the new tools. If we can have them more accessible and used to identify people with tuberculosis. Thank you, Stella, for accepting to present our Uganda experience. Over.
Thank you so much, Dr. Stavia. And it would not be possible without your support and both politically and then from an implementation perspective. We're seeing a lot of progress in Uganda, and today the project we're hearing is only one of the initiative in Uganda. And our next welcome speaker, Dr. Aldo, I'm sure he has more to say on all the X-ray case finding activity, because he is the senior case finding coordinator within the NTLP in Uganda, and then has been seconded by USA local partner health service TB activity, and he leads a lot of scale up project, active case project in Uganda, including the rollout of digital X-ray and CAT technology to improve TB case detection. So Dr. Aldo, I'll pass the mic to you.
Yes, thank you. Good afternoon, everyone. And I would like to thank you all for turning up for this webinar. And I would like to also thank my program manager, Dr. Stavia, for the welcome remarks. And I think I will add to what has been said already. We have, over the years, gained tremendous experience in the implementation of digital X-ray and the CAD technologies. In the last 3 years, we acquired a total of about 12 digital X-ray portable systems, which have been placed at health facilities, and we've learned a lot in the implementation. And recently this year, we also acquired 2 mobile clinics, which has also enabled us to reach out to communities, specifically those which have been defined as hotspots through our national TB prevalence survey and then recommendations. And through this, we have been able to reach to a number of communities. And we are really happy that in this particular webinar, we are going to learn more from one of our own implementers that have done the validation of the threshold score for using CAD, because as you notice that we have been following what has been recommended by the suppliers of the system of 50%, but we will get to appreciate from the presentation that probably this varies significantly in different settings, and to be really a good point of information for us to determine what's the most appropriate score to guide our country implementation. Of course, the implementation of digital X-ray comes with the challenges, and I think it's important for us to appreciate how to overcome these challenges in order to succeed. One of the key challenges has been mainly around capacity. These are new technologies. Sometimes our implementers on ground may lack some of the required IT skills to use the systems. And also we have been able to use other healthcare workers who are not necessarily expert radiographers, so like clinicians, and these have been found to be very helpful in scaling up the implementation. So it's quite a good opportunity for us to learn through this discussion, and appreciate what the teams have been able to do out in the field. I really want to thank you once again, and we look forward to a successful discussion. Thank you, and over to you, Zizim.
Thank you so much, Dr. Aldo. And now is the moment that we're all waiting for. Now I welcome Dr. Stella. She is the Senior Operational Research Advisor to USA, to IDI and the USA's project. And in her role, she has supervised and provide technical supervision to the development and the conduct of various research that are implementation or operational research. And today she will present the results from the 2021 TB Reach with 8 projects that the IDI received to pilot the CAP for TB version 7 and her results on the threshold score, the selection of threshold score. And a few words on the TB Reach initiative, for those who doesn't know this before. This is the initiative within Stop TB and is funded primarily by the Government of Canada, USAID, and UK's Foreign Commonwealth and Development Office. And this is an initiative that gave out small grant to test out innovation to improve TB case finding and care delivery. Since the creation in 2010, TB Reach has supported over 13 pilot projects, just like the one that we will hear today. Now, I'll just stop here, and Dr. Stella, now the floor is yours. We can start sharing your screen.
Thank you, Zizeng. Good morning or good afternoon, everyone, from where you are logging in, and greetings from Uganda, from the Infectious Diseases Institute, where we work closely with the NTLP to try and give the best care that we can to our people with TB. So today, on behalf of the Prime TB team, I'm here to present the calibration of the CAD for TB version 7 system for detection of chest X-ray abnormalities associated with TB. I will put on my video briefly, and then I'll take it off to save bandwidth. So, this, as Zizeng has said, this validation was part of a TB Reach project through the Wave 8 funding mechanism. And the TB Reach is sponsored by the WHO Stop TB Partnership. And so this was a small project in 3 districts in northern Uganda, which were high burden districts. And it had a programmatic aim and also an implementation research aim. So the programmatic aim was to increase TB case detection through engagement of private health providers in TB screening and diagnosis. And this was carried out in 3 districts, Kitgum, Lira, and Gulu. And the implementation research aim was to calibrate what was the new version then of CAD for TB, version 7, for the Ugandan population. So for the presentation, we will not talk about the programmatic aim, the results. I will just dive directly into the results for the implementation research aim. So a brief history of chest X-ray. Chest X-ray has historically been one of the primary methods used for the diagnosis of TB. And in the 50s and 60s, developed countries held large-scale screening campaigns using mobile X-ray units to detect and treat patients with TB. And these mass screening campaigns were very successful at detecting large pools of prevalent cases and resulted in significant reductions in TB burden. However, the campaigns were very expensive, and once the burden of TB was significantly reduced, they were abandoned in favor of symptom screening. And currently in developed countries, chest X-ray screening is reserved for selected places like immigration centers. When people want to immigrate, usually you need to have a chest X-ray to rule out TB and a number of other tests. So in developing countries, the mass screening with chest X-ray was never quite carried out in the earlier days because it was too expensive and logistically challenging to implement. And then X-ray, although very sensitive, had poor specificity and had diverse intra and inter-reader variability. And so the policy for TB screening in most of our high burden countries in sub-Saharan Africa and Southeast Asia has been to screen using symptoms and then combine with microscopy, and now combined with chest X-ray. And until very recently, we've only been using X-ray as part of the diagnostic workup for patients with smear negative TB. However, the pendulum is swinging back in favor of chest X-ray for TB screening for a number of reasons. The first one is that the prevalence surveys carried out over the past about 7 or 10 years all demonstrated that a significant proportion of TB cases were asymptomatic and were missed by symptom screening. And then also we've had global priorities shifted from the Stop TB strategy, which was find the most infectious cases and treat them, to the End TB strategy, which is find all all TB cases, get all of them to treatment and ensure that all of them complete treatment. So our priorities have shifted, and then we've had advancement in digital radiography, which has led to reduced costs, better image quality, lower radiation dosages, and the ability to transfer sorry about that. So the ability to transfer digital images from one place to another so that expert readers, don't have to be in far off places up country. They can be in the capital, and these images can be transferred to them and they can read them. And then with all that came the new kid on the block, which is computer-aided detection, which then not replaces, but to a large extent helps with reading chest X-rays, so that we don't have to rely on experts who are few and far between, and also cannot get through a whole load of X-rays in a short time. So computer-aided programs, they can standardize interpretation of X-rays, they reduce inter-reader variability, and they're very, very quick. So they can get through a large load of X-rays in a very short time. And so those advancements have now led us to a place where the consideration of chest X-ray in TB screening is a real possibility. And there are a number of ways that we can combine chest X-ray with TB screening. We can use it following a symptom screen. We can use it as the first screen, followed by microscopy or followed by X-ray if you have it. Or you can sort of modify the symptom screen to say any TB symptom instead of cough for more than 2 weeks. And then do a chest X-ray and then follow that up. So these many variabilities have now led to programs sort of like deciding how to use X-ray maybe at the facility or how to use it in community outreaches. And there are many different types of combinations. And the different types of combinations invariably will need different threshold scores. So these computer-aided systems, which I'm sure everyone in the audience knows very well, they detect textural abnormalities or abnormalities with shape or abnormalities like focal lesions, and they give the chest X-ray a score. And in our picture, you see that score is 83. So the score is usually between 0 to 100. And the higher the score, the higher the likelihood of TB. And usually different programs have to decide which threshold score to use to then decide who goes on to a diagnostic test, which is like the gene expert test or the sputum microscopy, depending on what. So why did we carry out this calibration? We carried out this calibration because TB pathophysiology is diverse and depends on many things, depends on age, depends on how much co-infection with HIV you have in a population, what severity of disease people present with. And so adequate utilization of CAD therefore requires adaptation to abnormality scores in individual populations with their own specific characteristics. Therefore, our study objective was to determine the sensitivity and specificity of different CAD for TB scores for the detection of bacteriologically confirmed TB in the Ugandan population, and to determine what would be an ideal score given the different sensitivities and specificities. So for our study, we used patients older than 15 years, presenting to the outpatient department and HIV clinics at the 2 hospitals. For our study, for HIV, we included all patients who are newly diagnosed with HIV, regardless of symptomology. All patients returning to care after being lost to follow up for more than 3 months, and all patients coming in for ART refill who had any cough of any duration. And for the HIV negatives, we included patients any cough of any duration, plus or minus 1 or more signs of TB, symptoms of TB. We excluded patients who are unable to provide informed consent, patients who are already on TB treatment, and patients who were expecting because we did not want to expose them to radiation. So for our and this is something I have to say, because when we see the results, we have to interpret them cautiously. The chest X-ray was not the initial screen. The chest X-ray was a follow-on screen after a symptom screen. I'll keep emphasizing that as we go through the results, because the threshold score will be different depending on where you place the chest X-ray. So these were patients who came in, first of all, they're in the hospital, so they have some symptomology of some sort. And we needed to do the expert on all of them. So we took patients who had cough. We did not care about the duration of the cough, but the patients had to have cough. Yes, so this is sort of the patient flow chart. If a patient attended OPD, And they got all patients who attended OPD got a symptom screen, and if they had any cough and plus or minus any other symptom, they got an HIV test and they got a pregnancy test. And patients who attended HIV clinic also had a symptom screen, and cough of any duration was sent to the chest X-ray. So all patients who fit the inclusion criteria received a chest X-ray and the gene expert test. And if they had MTB, they were treated for TB at the hospital. If they had rifampicin resistance, they were then treated for MDR TB at that hospital. The two hospitals both had MDR TB treatment available. And if they had an abnormal chest X-ray, like a really high threshold score, but a negative TB test, a negative gene expert test, they were referred to the physician for further evaluation and management. And if they had a negative chest X-ray and no gene expert, then they were sent home or managed for something else that they came in with. So these were our study results. We had 1,500 patients who were screened. We eliminated 137 patients because some had unproductive cough, and we did not have a means to induce sputum. And this is, we'll talk about this, one of the weaknesses of our study. We couldn't induce sputum. Then others declined to participate or were already on TB treatment or were pregnant. We had one patient who we couldn't find their enrollment data. So in the end, we had 1,363 patients. And of these, the patients who had both a gene expert test result and a chest X-ray test result were 1,345. So in our results, our patients were, there was no difference between the HIV positives and negatives in terms of median age or gender or BMI. There were some differences in terms of age. The HIV negative cohort was was a little bit older. Yes, and maybe some differences in. We had 97 patients who HIV positive patients who had had a previous history of TB, and 61 of the HIV negatives. And so we had overall, we had a number of patients who had cough only of any duration with no other symptoms. The majority of our patients had cough for less than 2 weeks, but with another symptom, and some had cough for more than 2 weeks. So there was some co-infection with other illnesses, but that was really low. And alcohol intake and tobacco use for all.
Stella, I think we don't hear you. Can you check your connection?
Sorry. No, I was muted. I was talking, but I
Okay.
was muted.
There you go.
Yes. So we ended up starting 39 patients on TB treatment who were HIV positive, and 59 who were HIV negative. And of those who were started on treatment, there were a few with low threshold, low card for TB scores, but positive gene expert. And those were mostly the HIV positives. So these were patients who had very low scores, but when we did the gene expert test, they were positive. We see the majority of them were HIV positive. Among the HIV negatives, there were very few who had, let's say only 2 who had a threshold, a card for TB score of less than 20, but were had positive gene expert tests. And we see as we go higher, most positive gene expert tests had a card for TB scores, which were really high. Then we also had some high card scores, which was above 50, but a negative gene expert test. And most of these ones who were started on treatment were reviewed by the clinicians, and a clinical decision was made based on symptomology, based on the chest x-ray, what the chest x-ray looked like. A clinical decision was made to start them on TB treatment. When we get to the calculating the sensitivity and specificity of different scores, different threshold scores, we find that overall, this is combining all the HIV positives and the HIV negatives. So looking at everyone who was in the study, and also wanting to set our cutoff for sensitivity at around 90% and specificity at 70%. And this is because this is the WHO recommendation for screening tests for TB, to have at least a sensitivity of around 90 and a specificity of about 70. So when we did that, we found that among patients who are presenting at health facilities, for whom chest X-ray is used as the second screen, not a first screen, the close ideal cutoff score was 30% if you combine all the HIV positives and negatives. So that 20%, I was able to detect 53 out of 61 prevalent cases, and was managed to save almost 1,000 cartridges, that cutoff point. It gave us an expert positivity rate of about 14%. So when we disaggregated by HIV positive and HIV negative, we found that the ideal threshold score for HIV positives is lower. It was about the one that gave us a cutoff point of close to 90 sensitivity and close to 70 sensitivity was about 15 for the HIV positives. And this at this, if we had cut it off at this, we would have been able to diagnose 23 out of 26 prevalent cases in that population, which was the proportion is about 88%, sorry. And we would have saved more than half, no, more than 2/3 of the expert tests that we used. So if we go on to the HIV negatives, now only considering the HIV negatives, we find that a threshold score of greater than 30 gave us a sensitivity of 91% and a specificity of 83%, and was able to diagnose 31 out of 34 expert positive cases, and would have saved close to 600 So the number of experts saved was very, very big. If we had used this cutoff score, we would have saved 575 out of the 723. So we can do the percentages. That's about more than 60% of expert cartridges. So this is sort of like just a graphic explanation of a cutoff score of 90% sensitivity, how it would differ overall and among HIV positives and HIV negatives. This is and Zizing, I would ask that you explained this very well when we talked about this. So this was the ROC curves. So the ROC curves give you the UN index, which is sort of the point at which the curve starts to the curve starts to, I was going to say the curve starts to curve, but at the point at which it stops going vertically and starts going horizontally, that gave us a different threshold score, but the associated sensitivity and specificity were quite low. Which means that if we had used these threshold scores in patients at the health facility, we would have missed quite a number of TB cases. So this is where we need to sort of debate on which threshold scores to use, depending on the aim of finding activity. So this is, so if we had used the threshold scores from the ROC curves, we still save a very high number of expert tests. But if we use the WHO sensitivity cutoff of 90%, we find more cases and really save many genes. So card calibration analysis should be carefully interpreted in the context of the intended screening program. When card is being used to maximize case detection, then it's used as a fast screen. However, if it's being used to improve the efficiency of a triage system, it's preceded by an earlier screening, an earlier symptom screen, and therefore those thresholds would be different. So yes, so the implications of this study is that we use about 700,000 tests, expert tests annually. And if we could add chest X-ray with CAT to the screening algorithm at the health facility, we could significantly reduce the number of expert tests needed with minimal reduction in the number of TB cases diagnosed. The follow-on benefits may include a reduced sputum turnaround time, reductions in pre-treatment loss to follow-up, because we know that one of the leading causes of pre-treatment loss to follow-up is a long turnaround time. And since pre-treatment loss to follow-up leads to mortality, this could also lead to, down the road, ultimately, could lead to reductions in mortality. However, we have to balance this against the cost of card, the cost of chest X-ray maintenance, and the cost of personnel to operate the chest X-rays. Yes, so the acknowledgements go out to the Card for TB team, the Prime TB team, to the Ministry of Health and the NTLP, and to the Stop TB Partnership, which funded this study. Thank you very much. Back to you, Zizeng.
Thank you very much, Dr. Stella. And now the floor is open. Anyone have any questions? Feel free to raise your hand using the hand button, and now I can call it out to you. or else you can type your question in the chat group. Okay, so there's one question from Brenda, our colleague from Kenya. So thank your team. Quick question. The calculation on expert saving was comparing a score of 0, or what would be the practice? And
Yes, so the calculation of X-ray of expert saving was, yes, you could say compared to a score of 0, compared to if you didn't have CAD at all as a second screen. So if you took a symptomatic patients with cough of any duration and subjected all of them to an expert test.
right, so it's like as if we're doing universal gene expert.
Yes.
Okay, thank you. The next question just come in. So what is from colleague from Afghanistan? What CAF for TB threshold do you recommend in low HIV setting?
So in settings where you have very little HIV, you could probably use, of course, you have to calibrate it for your own population, but probably a higher score, maybe about 30, if you were using it at the facility as a second screen, which was, maybe I can just project the threshold score for HIV negatives was higher, you know? So if you cut it off at 30, you would have a sensitivity of 90% and very high sensitivity and very high specificity. So for the HIV, so if you have very, very low setting, then you would have a higher threshold score. In our population, we had a number of HIV positive, and we know that HIV, that the chest X-ray abnormalities, because HIV people cannot mount on, sometimes their chest X-rays, the abnormalities are not very distinct. So they're easier to miss among the HIV positives. Okay.
And Dr. Kadir, and I just wanted to give you this opportunity because people always ask about HIV, people living with HIV and those who without HIV status. Just wanted to give you this opportunity to ask any follow-up question that you might have regarding what Dr. Stella responded. Clear on the threshold score in low HIV setting. And you can just unmute yourself to respond if you want to. Okay, so it's good for you. Okay. Okay, good. Okay, I see Dr. Inosa. I may not pronounce your name correctly, but please go ahead. I see your hand is up.
Yes, thank you. Thank Dr. Stella and your team for this great study. Really, very, very interesting. So I have a quick question because WHO released, I think, 2 months ago, like consultation, meeting, not like recommendation, but some orientation, I would say, waiting there. I think they will release a recommendation maybe by end of this year or early next year on chest X-ray and digital chest X-ray recommendations, kind of, for TB screening among people living with HIV and general population. So I don't know if you, in your study, you did some triangulation with CD4 counts, because based on WHO document, the threshold may change based on CD4 count and inpatient versus outpatients. I don't know if you did some kind of triangulation and calculation. I don't know. Over.
Yes, yes, very good question. And yes, definitely the score would change depending on CD4 cell count. So we did not do CD4 cell counts because right now we are, as a country, I think we are more focused on doing viral loads than CD4 cell count. So we only do a CD4 cell count for the newly diagnosed. But we also know that in our country, it may not be everywhere, but in our country, then the highest, not highest, but about 30% of newly diagnosed HIV patients have advanced HIV disease, which is a CD4 count of less than 200. So that's generally speaking, although we didn't measure it in this study. So it is, it's likely that these patients, who, especially the HIV positives who are coming in through OPD, because those were newly diagnosed, it's likely that they had a low CD4, and that's why they had very many low scores, which ended up having MTB. However, practically speaking, so we had these 6 here in MTB, but difficult to have for the newly diagnosed, not for the ones who are in treatment, to have a CD4 available to you at the time you will make that decision, whether to send someone for the expert, because the card for TB score is available immediately, but the CD4, if you took off the, maybe 2, 3, 4 days. So in the outpatient setting, it's difficult to then use that as an additional criteria to decide whether you take a patient to the lab or not, because you won't have it with you there. But the card for TB score, you have it with you, it's 1 minute, you have it, and then you quickly have to decide whether you should send the patient to an expert or not. So yeah, so those are the sort of like the operational considerations.
Does that answer your question? Or if you have follow-up question?
Yes, thank you so much. That's very impressive. Really, I really appreciate that. Yeah, just a like overall comment. I think we used to recommend, using digital test rate in clinical signs symptoms, and as a general recommendation, I will say, yeah, digital test rate is a very good tool, very high sensitivity, for TB case finding. Yeah, but we should also, as clinicians, nurses in the field, healthcare workers, pay attention on clinical signs, symptoms, physical examination, which will help, at the end, to decide if the patient needs molecular tests or not. This is very important, because even based on the best tool, we still need, patient to be assessed clinically and take the further the best decision, in terms of asking sputum and molecular test. So yeah, for me, GSS-ray is okay. It's very good, very sensitive tool, but we still need this kind of clinical symptoms, physical examination, and then take the final decision in terms of asking for molecular tests. Yeah. Over.
Yeah, so if I just add one remark. Clinical symptoms, it's always recommended to do parallel screening, symptoms, clinical assessments with symptom and other clinical sign in parallel with digital X-ray. We've been talking about digital X-ray just because we have been doing symptomatic screening and clinical assessment. That's the baseline. Now we're adding digital X-ray onto this to hope that by doing both in parallel, then we can find those who are symptomatic and asymptomatic with checks X-ray abnormal to both get a test, confirmation test, laboratory test for TB, to miss either arms. So next question, I think is also about HIV. This is from So from IDDS Burma, I think. In Burma context, we don't routinely ask for HIV status to attendees at active case finding activity. So this is actually very common in a lot of Southeast Asia country setting because the no-HIV status is just a bit low. So HIV status is not routinely collected. Then, so we need to assume the HIV prevalence at very low rate, assuming attendee as general population. In this setting, I would like to know whether we can set a single value of threshold of all ACF activity unless that ACF is not focused on HIV key population. Stella, do you want to take this, give it a first go? I don't know if you're speaking, probably is on mute, so we're not hearing you.
Yes, I was speaking. So for active case finding, I think you would normally use the chest X-ray as the initial screen, not so? So I have, well, two answers to give. One is that, yes, so it's for us in the clinic setting, all patients with presumptive TB should get an HIV test. So because we are a high burden HIV country, so it's easy to implement something like this to know that there'll be different threshold scores. But for countries which have very low HIV prevalence, and I think it's reasonable to assume one cutoff score for everyone, unless you're focusing on HIV key populations, those pockets where HIV prevalence will be high. However, I would like to say that if you are using the chest X-ray and CAD as the initial screening, that threshold score will likely be different. Because here we were using it as a follow-on screen. So it would be best for you to do a short study and calibrate it for active case finding within your study, within your population. And just also to note that even for us as Uganda, we are planning to do another study to calibrate it for active case finding activities, because that will be different. In active case finding, usually because everyone is in the same place at the same time, usually you screen everyone with chest X-ray first, and then whoever has an abnormal X-ray is the one you send for gene expert screening. You don't usually do a symptom screen first for active case finding. Yeah, I hope my answer is clear, Zizeng.
Yeah, super clear.
It's
No,
not.
yeah, it's very clear. Thanks so much. I wonder, we have a few minutes left, and I see one more question, and I just want to pose this question to get a sense from you, because it's good to have this back and forth from, as you can see on the screen, where Dr. Stella highlighted, to get 90%, close to 90% sensitivity. So at 86%, 87% sensitivity, the threshold score is actually at 20. Remember at the beginning, both Dr. Stavia, although Dr. Stella mentioned that the supplier based on the supplier's recommendation, they said the threshold score at 50. Now, what do you think about the results which showing a much lower threshold score will be needed if you want to achieve 90% sensitivity as required by the WHO triage TB target product profile for the triage test? Any comment, any remark on the result that actually show a much lower threshold score than what's recommended by the supplier to use? So I see Dr. Elder, you raise your hand. Go ahead.
Yes, thank you. In fact, these findings are really very powerful, and they will influence our decisions in implementation. I'm looking at the programmatic implications of these findings. We really need to sit and discuss what we are going to do, because we have also seen in the implementation from the field that there are some individuals who have a low score because we are now collecting samples from almost everyone for the community case finding using the mobile clinics, and they have ended up being birth risk confirmed. So if we are to stick to the 50% threshold, then we would have missed them. So I think what I'm looking here is there are implications definitely in these findings, and we need to adopt them in our implementation. But bearing in mind also that when we lower these scores, and then that means the cost of screening is likely to go up because the demand for expert testing will also increase. So all these need to be really looked at, and I'll be really glad to know what is the recommendation for the program in terms of what can we adopt moving forward. Thank you.
Thank you so much. I cannot see who else raised the hand. Sorry, yeah, Dr. Brenda, go ahead.
All right, so thank you, and thank you very much to the Ugandan team. I think this is very thought-provoking and interesting. So I think just taking it on like the question you'd asked, because I was also thinking about that. The reason I asked whether you did a costing comparison, because even though you saved, for example, where you've just pointed to, you've saved 973 tests to get 53 cases. If you go down to your 50, for example, so I was wondering whether the difference in the, the expert test saved to get an additional, okay, this is a little higher. So I would say like 45 to get an additional three patients. So, I mean, I think programmatic, it's also usually always a balance between resources and the number of cases that you can get. So if you're doing this wide scale, I would just wonder whether the recommendation of 20 is still, you know, what you would advise, or, you know, use a little bit higher, but, you know, at the end of the day, still allow the clinicians to decide any that they still think should get a bacteriological confirmation. Yeah, because otherwise then it would look like you'd actually, in my view, still do quite many tests. Yeah, so what's the balance? Yeah, thanks.
Zenk, let me ask, sort of like clarify a few things. So Beatrice, so this 973, which is almost 1,000, is the number of experts saved. The number of experts saved, if you cut it off at that point, like if you don't send everyone for chest x-ray, and you say, let's first, after you're symptomatic, you've come to the clinic, let's first do a chest x-ray. We won't send everyone for expert, we'll do a chest x-ray, and those above 20 will go to the expert. So in that case, you're saving almost 1,000 expert tests. If you use a lower threshold, you save 1,100. So you use an additional 100 tests, but you lose many TB patients because you've lost about 6 TB patients between, you know, 20 and 40. So if you are using chest x-ray as a second screen, then you want to save as many expert tests as you can while finding as many TB cases as you can, because you're using it as a second screen, not as an initial screen. So that is why as a second screen, the lower threshold sort of is feasible, because otherwise, if you didn't have it, everyone would go for the expert, you know? So if you're using it as a second screen, you want to get as low a score as you can to save you expert tests while finding UTB cases. That's if you're using it as a second screen, which is what we did. If you're using it as an initial screen, which was all those questions, that when they're using it as an initial screen, if they set the threshold score too low, then they might be testing people unnecessarily. And that is why we need data from this setting, where the CAD for TB score is the first test. You know, because then you're trying to see how many people then go on to the second test. The consideration is different, depending in this consideration, a lower score is better, because otherwise all these people would go on to an expert test and you'd waste many expert cartridges, you know. So in this consideration, even if you set it as low as 15, you would still save 900 tests while finding 57 cases. So when you use expert as a second screen, a lower score is better. When you use it as a first screen, it's a different story. So we need to get data from that setting and actually look at it and say, what is the most sort of like cost-effective cutoff score to use when you use it as a first screen?
Thank you, Stella. I see a lot of people in the group are actually implementing partner have tried to solve the threshold score issue in their own country. I just wanted to quickly get a sense from the audience if any one of you have any things to contribute to discuss about the threshold score, the fact that we're seeing in this one study a much lower threshold score than what's being used by most program. What does it mean to you now that you've seen the results, or just to share your experience? If you've been using 50 as the threshold score, have you experienced issues with the with lost people been missed from checks X-raying your screening algorithm? I see, Austin, you wrote something in the chat. Why don't you speak up with a microphone? Do you want to speak up in live using this Zoom? Austin, I don't know if you're speaking, but you are on mute. Well, just in the meantime, I'll just read out what he says in the chat. I think the difference between the recommended CAS score from the supplier and the study finding may be depend on the number of factors, which could include the type of screening algorithm used, the prevalence of TB in the population, and the type of population, parentheses, community versus facility-based, used by the supplier for their data analysis. The study was focused on facility-based population and used symptom as a first test. And okay, so he couldn't speak because he's in a physical meeting, I see. Now, Brenda, I see you're still noting. I think what we note is very low yield for score below 42 to 5%. Expert positivity yield. Okay, so in Kenya, in Brenda experience, we use even 40 as the score. The yield is 2.225% expert positivity yield. Just going back to Austin's point where he said that the study is facility-based population and then symptom screening is as a first test. Now, if we're really moving to the community, the prevalence of TB would arguably be lower than what's in the facility-based screening, and then if we're without using symptom first, if we're using it parallel, arguably the score that we need to use is even lower than what we're seeing here in the facility-based. And it's true, yes, the study is done probably in a different population than the manufacturers. And from what I'm seeing, if you're going to a more peripheral, more general population, the threshold scores need to be even lower. Anyone have any last remark on this topic on threshold score? If not, we have an excellent presentation from Anne, who's also in the audience from Vietnam FHI last time in webinar 7. She also looked at systematically from the practical data that are collected through implementation and how to use them to address threshold score selection problem. Not just looking at sensitivity, but also looking at a few other programmatic setting requirements. So for those who are interested in dig deeper into threshold score, feel free to look at it. I will send the link to her webinar in the chat group momentarily. Okay. So before we close, just wanted to say if there's any other closing remark, any closing question. If not, I would like to ask Dr. Stavia to say a few words, who stayed with us during the entire webinar. And now that she has seen that there's a lot of discussion and then a lot of good experience and good learning from the study that IDI, that Dr. Stella conducted. I wonder if she wanted to say a few words to close our session today. And Dr. Stavia, the floor is yours.
Thank you, Suzanne. Thank you, Stella, for the wonderful presentation and the findings. The findings are very useful for us who are beginning to scale up the use of the digital X-ray technology and CAD for TB. But like you have seen members from the study, we focused on people who are seeking care at facilities. So and also use symptom screen as the first tool, not CAD for TB screening. So the finding should be interpreted with that in context as you plan to see whether you need to review your cutoff in your respective countries. And like I said in the beginning, we are a high burden TB country, and this study specifically was done in one of the sub-regions where there's more TB, as we see from the notification data compared to other sub-regions. So all these factors definitely affect the likely cutoff that would be identified. But the finding, I know if we sit down with our technical committee team, should be able to inform a lot our current implementation. I encourage you, Stella, to make sure that we do further use of this finding. We'll continue to dig further, especially when we do screening at the community level. What is it that we see, and also in different settings, to see whether we can find the best way to do the screening using this approach. So thank you, all of us who have logged on for the time and for the useful comments and suggestions that you bring on board. Thank you, Stop TB, for organizing. Over.
Thank you so much, Dr. Stavia, and thank you for everybody who participated in the webinar. And thank you, obviously, to Dr. Stella, her team. It's a really important presentation, and it's very helpful. Where I can speak on behalf of a lot of people here on the group. Very rich and informative presentation. Thank you, everyone. Take care.
Thank you. Bye.
Thank you, and have a good rest of the day.